Hello and welcome back to Season 2 of Fertility Talks, the Therapy Fertility podcast. I'm your host, Ranae von Meding, and I'm so excited to be back hosting our second season of this podcast, bringing you honest conversation and information about infertility and fertility treatment in Ireland. Each week, I'll be sitting down with a different guest and chatting all things fertility. As always, our hope for this series is that we can strip away some of the stigma that sometimes comes hand in hand with infertility and fertility treatment. This week, I'm very excited to have a special guest, our head of nursing at Therapy Fertility, Melissa Mark. Welcome, Melissa.
Hi, Renee.
Thank you so much for agreeing to be our very first guest this season.
Thank you for inviting me.
Is this your first podcast?
It is. I can tell I'm a little bit nervous.
Well, you've done other things like this with me, so you will be fine.
You put me at ease. So.
Good. So I was just thinking that we're going to just kick off, and if you would like to maybe tell our listeners and our watchers what brought you to Therapy Fertility and what was that journey for you? How did you start your career in nursing and fertility?
So I suppose I think I'm a little bit more unusual in that I'm general trained, because I find that infertility, a lot of the nursing team are midwife backgrounds. So I trained in Scotland and I actually trained with a girl from Dublin. That's how I ended up over here. There was a job she'd moved home and there was a job here, and I came over for a year, and that's 12 or 13 years ago now. Was working in a dialysis-based position, and very luckily just got an opportunity to help out in a fertility clinic. And when I went there, I was like, this is the place for me. Just found it so interesting. I still find it so interesting every day. So I've worked in fertility 7.5 years, I think now, and then got an opportunity to come on board with therapy last year, which I jumped at. So
funny. I didn't know you used to work in dialysis. I would have just,
really?
I knew you worked in general, but I would have thought you worked in fertility forever, because anyone who meets you, and I think anyone who's come to the clinic and has had you, would just feels your enthusiasm and love for the field.
I really do. I've never have that feel. I mean, okay, some Monday mornings you might think, oh, I'd rather not go into work, but I never ever feel like I don't want to go to work. I find it such an enjoyable environment to be in. I think the fact that infertility things change so much all the time, it's always so interesting, and it's really specialised. And from a nursing point of view, I love that. Yeah.
Okay, so let's talk about Therapy Fertility. Yeah. So we've been open since last July.
Yeah, so started seeing patients in July, and then started sort of procedures and treatments then in the September. And things are just progressing fantastically. We're so happy.
It's busy, right?
It is, yeah. So I suppose Therapy Fertility is a little bit different in that we are a nurse-led clinic. So how we're doing things in therapy is a little bit different to where I've worked before as well. And the biggest difference being that when patients come in to therapy, they're initially seen by a nurse.
Yeah. So one of the biggest things is that it's nurse-led. What are the other kind of headline items that make us a little bit different?
I think we'll have to talk about the fact that the cost of treatment with us is much cheaper. I think that certainly we're making it a little bit more accessible to people. I think cost is something that we all knew was a factor for people's treatment, but none of us really appreciated how much until we started seeing people. I would say a lot of younger people coming through, and people who will just say to you, I would never have been able to afford to go ahead with treatment. People that I've met, patients that had actually been in contact with clinics to go abroad because financially that was better
so
for
many
them.
people over the last decade and more have been going abroad. And one of the reasons is
forced to nearly. But we've had people that were almost in the process of, signing consents and things to go, and then we're just like, thank goodness we've got this opportunity to stay in Ireland and have treatment here. So Cost is a big factor.
Okay. And then I think the other kind of big thing is the kind of streamlining of the actual services that are offered, as opposed to offering everything.
Yeah.
It's kind of offering a fewer things, but doing them really, really well.
Yeah, and that's something that obviously is a vision of John's, Dr. Kennedy's,
Sure.
to have that. And I think something that our team has came from loads of different clinics, which is fantastic. We have so much different experiences and things there. And I think we thought that going into this would be a little bit harder pulling back from all of that, because we've all came from places where we did all these add-ons and extras, and you're really invested in them when you're doing them. But we've all just taken a step back. So, and it just is made it so much easier, I think, for patients. I think one of the things that because we thought there'd be a lot of, not pushback from patients, but they'd kind of almost be put off a little bit by that. But I find that patients are kind of thinking, oh, great, okay, so I don't need to make this decision to go ahead with something that because they were almost in this situation where they felt like something had been suggested and they felt if they didn't do it.
And then if it was unsuccessful, it would
be on them.
Negatively
impacted on their treatment.
I personally know from going through treatment myself and my wife that if there was ever talk of anything extra, of course you're going to find the money to do it. Of course you are, because you're putting so much money and effort and time and everything into this that if there's even a chance that something that costs an extra $1,000 is going to help, and you're going to try it.
I mean, I think from my point of view, even, it was kind of, we were always like, we're dotting the I's, we're crossing the T's, we're
just in case.
And you really, and I think we probably, if we're honest, everybody in there kind of all was maybe a little bit nervous about what was stepping back from this going to impact on things. And just like the results that we're seeing, it's just fantastic, and it's so reassuring. And I think we're all just really on board with that sort of more streamlined processes that we're doing. We're just taking a lot of the noise away from.
So it's really just kind of back to basics and the things that are kind of evidence-based and proven.
And that's kind of what I would say to people when I'm meeting them. Sometimes they'll come in, having been maybe done treatment elsewhere, or they know somebody that's done something, and they'll ask us about it. And it's having that sort of conviction to say, do you know what, there isn't the evidence to say that that's any benefit. And we're not trying to put down any other places where they are doing it. I think there's definitely places for certain treatments, but here we're just trying to really, as you said, focus on doing the basics really, really well. Yeah.
Okay, so let's talk about when someone first comes to therapy. What are the options that they have? Like, what are those things that we're offering?
So the treatments that we're offering in therapy are IUIs, Ivf or Xe. Then we're looking at options for same-sex couples. So it would be Ivf and Xe with donor sperm, or reciprocal Ivf. And then there's also the treatment using donor sperm as well.
Yep. Okay.
And sorry, I should mention egg freezing as well.
Yeah, which is big one for us.
Yeah, really.
Okay. So let's talk just briefly about Ivf and Xe. So most people listening to this will kind of have a good idea of what Ivf and Xe is, but for some people who maybe don't know, it you kind of get this image of like eggs and sperm and a petri dish, and
which is I suppose essentially
it's not wrong.
When we talk about IVF, it's talking about fertilization of egg and sperm happening out with the body, so in a lab environment.
Okay, so how do you get eggs? How do you get sperm?
So the IVF process for the female coming through, I suppose the hardest bit of work is done in the lead up to that, and that's by taking medications. Those medications are injections, which sometimes people are a bit nervous about, but they are all pros by the end of it. So essentially you take some medications to stimulate your ovaries. So we're trying to mimic really what's happening in a natural cycle, but where there's one
times it by 100.
Where there's one follicle growing in a natural cycle, we're trying to get more follicles to grow. And we monitor your response to medications through ultrasound scans, and then we bring that person in for an egg collection procedure.
So the eggs are essentially collected.
Yes. So an egg collection procedure is probably the most daunting part of the cycle, I would say, for a person. I'm the worst patient in the world, Ranae. I'm sure I've worked with some doctors that say I never want to treat you because I'd be a real nervous person. So I totally understand that. And it's trying to just explain to people that it is something that is outpatient's procedure. So it's trying to what am I trying to say here? I'm trying to not downplay it, but just say that it's something that you would absolutely tolerate.
You'd be totally fine.
Yes,
yeah,
yes.
It's not something that anyone wants. It's not like
absolutely
a day at the spa.
Yeah,
but you do get some nice medication.
Yeah, you feel a bit, a bit relaxed. The thing is, when you come in for an egg collection, there's no point in me telling you, don't worry about it.
Oh, you'll be fine. Yeah.
Like I know I wouldn't sleep the night before it and
Sure.
I'd be nervous, but what I try to say to people is that when you come in for your procedure, you can bring your partner in with you into the sort of ward area, or if you were coming through on your own, you can have somebody come through with you while
Sure.
you get ready. When you actually go through for the procedure, you have to go through on your own, but there's a nurse that's allocated there, and all she's doing is looking
supporting
after you. Yeah, that's
Isn't
all
that
she's
lovely?
doing. So when you go into the procedure room, she'd be there. There'll also be a doctor, and then there'll be a second nurse or healthcare assistant
Who's helping with the
assisting
procedure.
Yeah. And you'd also meet a member of the lab team as well, because
So those are the people who are actually going to be taking your eggs.
Yeah. So when you go into the procedure room, you'd be in a bed there, and there's a little window or a hatch there that goes through to the lab, and they'll say hello to you and introduce themselves as well before the procedure starts. You're looking at this procedure being 15-20 minutes, but you're going to be in the clinic for a couple of hours.
Just recovering afterwards.
Yeah. So we bring you in a sort of half an hour, 45 minutes before, because there's lots of prep. We need to bring you in fasted. We ask you lots of questions. We're going to get you ready, and then we bring you through into the procedure room, and then back through onto the ward to recover.
Okay, so once the eggs are collected, you need obviously sperm to complete the Ivf or Xe process.
Yes.
So how is that
So
obtained?
So there's two options there with either. So if somebody was coming through and they were using donor sperm, there'd be donor sperm already in storage in the clinic. That donor sperm sample would be thawed, and that would be used then for the fertilization.
So if it's Ivf, it's mixed in a dish.
Yes.
They're put together.
Yeah. Xe is essentially just a variation of IVF. So what we're doing with Xe is the embryologists are taking that sperm sample, they're looking at that sperm under the microscope, they're selecting single sperm, and then they are taking the eggs, they strip the outer cells off of the eggs, and they inject a single sperm into each egg.
And do they do this when maybe the sperm, like the motility, is not great?
Yes, so there's a few reasons why you might do Xe over IVF. Obviously, that's something that comes out of testing and things like that. But usually, if there's a sort of known male factor, we talk about an issue with the sperm, and that might be motility. Some of the other testing that we do, so things like the DNA fragmentation test, and if that levels were high, that can be an indication for Xe. Everything is very personalised to a couple coming through. There are different things that would indicate reasons for doing Xe, a person's history, if they've done treatment before.
Yeah.
So we that's all taken into account when you're making a selection for why you would do one over the other.
Okay. So, and if someone's coming through with a partner, their partner would give a sperm sample on the day.
Yeah. So they would, when the female partner is in having her egg collection, just before she'd go back through into recovery, the male partner would be brought through to the producing rooms there, and they would provide a sample for us there.
Perfect. And then same process.
Exactly the same process in
Cool.
the lab then.
Okay, so that's Ivf and Xe. Let's talk briefly about IUI. I know it's not as popular, but it still can be a good option for many
certainly
people.
IUI is an option for some people. So an IUI, I suppose it's a more basic step into the fertility treatment. It's not as invasive. Now, the actual medication regimes and things are very similar to an IVF. You still have to take injections, we still have to do the scans, but also you're not having that egg collection procedure.
Yeah, so the eggs are staying where they are in the body, they're not taken out.
Yeah, I'm not going to bring you in for an invasive egg collection, but what we do is we then give you a day to come in to the clinic. So the partner would provide a sperm sample. That sample is prepared in the lab, and then the actual insemination procedure is something similar to somebody having like a smear test. So definitely better ways to spend your time, but you know, it's a quick
it's kind of a way of getting the sperm closer to...
Yeah, that's exactly what we're trying to do. So we pass a speculum, so we can see the cervix. We pop a little catheter through that cervix, and then the catheter is just sitting into the uterus, and we inject the sperm sample, and the idea being that you're trying to get the sperm as close to the egg at the time of ovulation.
To kind of encourage fertilization to occur.
Yeah.
Okay.
And then also then if it was a donor sperm sample, the same process, the sperm is thawed in the lab, and we would just inject the sample.
And why might someone do IUI over IVF?
So there's a few reasons. Sometimes it's a patient comes into us and says that's what they want to do. And then so also things like financially, sometimes it can be a choice because it's a little bit cheaper. It's, as I said, it's a sort of more like it's a basic, a more basic sort of lead into treatment. Sometimes if we think there's nothing there that's indicating any reason for why this
someone's
couple
not
maybe
conceiving,
are not conceiving,
or if they're using donor sperm.
Yeah. So it's certainly, I would say that there is not a huge amount of people going through for IUI. The majority of people are coming to us or coming for an IVF
I know
cycle.
Talking to Dr. Kennedy on this quite a lot, and he always says that IVF and Xe, even when it is unsuccessful, you still learn something.
Yeah, and that's what I can always say to people, that if an IUI cycle doesn't work, we don't really gain information from it. Yeah. IVF is a little bit diagnostic when you're doing it, because you're obviously seeing the egg and sperm.
Yeah, so you can see and then you can see if it fertilizes, and then if it only gets to day 2 or if it gets to day 5. I always say to people that it's not that when I talk about that, I don't mean that we can say, oh look here, this is why it didn't work. We know it's not that, but we do get a little bit more information as opposed to if an IUI doesn't work.
Yeah.
You don't know anything.
But it's certainly, I think sometimes people just need to come in and do a round of IUI.
Just to see what it's like before they're ready. Yeah, for sure.
And it's a good, I suppose, way of maybe, because the medication regime is very similar, sometimes they just feel that they want to try that before doing an IVF.
And then for some people it's wildly successful.
Yeah, absolutely. Sometimes when I tell people that the medications, they come in very much with the idea of wanting to do an IUI.
And then when you tell them about the meds, they're like, okay, fine.
Well, in for a penny, in for a pound, sort of thing. And
I suppose the other good thing about Ivf and Xe is that if you are successful and if you have extra embryos, you get to freeze them, and then you get another shot at having another embryo transfer without having to do a whole cycle. And
it's and that's certainly something to consider, and I talk about with patients is that I always am trying. I never want to say to patients I don't want to be like a black cloud or anything, but I'm always kind of saying nothing that we do is a guarantee, but sometimes different options have got potentially better chances of outcome then.
Yeah, and I think it's really important to be realistic and not to be making promises you can't keep.
I think it's a fine line. I don't want to be that black cloud, but like you say, be realistic to patients. And I think most people appreciate that then.
I think so too. Okay, so let's move on to options for same-sex female couples. So obviously we've talked about IVF, Xe, IUI with donor sperm. That's obviously an option. And then we also do reciprocal IVF, which is my favorite topic.
So reciprocal IVF is essentially allowing a couple that one person can come through and do an egg collection and create embryos, and then those embryos are available to be used by either of the
or both. So usually in that case, one person will be the genetic parent, essentially, and the other will be the gestational parent.
Yeah.
So one gives eggs and one carries.
Yes. So it's fantastic to be able to
Isn't
give
it
that
gorgeous?
option
It
to
really
people.
is.
Yeah.
Like, you know, obviously this is how we had our 2 kids, and it just blows my mind, you know, that, you know, we live in a time where we can do this, and it's a beautiful way to have kids.
Yeah,
it really is. And I'm sure you've seen, you know, people coming through for this, and isn't it? It's just really special.
And although I don't think that, well, maybe working in fertility for 7 years is a long time, but you know, in the grand scheme of things, it's not a huge timeline. But to think that not that long ago we didn't have that option.
Yeah, sure.
For
like you couldn't do it in 2018.
Yeah.
It was only available from 2019, so very, very new.
And you know, initially we made people sort of donate all their eggs, and it kind of, this just makes it a much nicer process, I think. For it gives people more options. You know. So
I suppose the actual physical process of that is the exact same really as an IVF with donor sperm, except that one partner will do the stims and the egg collection, and the other partner will do the embryo transfer.
Yeah, and the important thing is that it's not, so there's not what we call synchronized cycles, so there won't be a fresh transfer from that. We do the egg collection
with one partner, create embryos,
they're frozen, and then
immediately following, or whenever
the
couple.
That's the beauty of freezing embryos.
Yeah, because you know, someone, you know, say if a couple are, you know, buying a house or getting married or whatever, they might want to get a head start on creating those embryos, because as we all know, the younger you are, usually the better quality the eggs are, the more eggs you'll get. But then they might just not be ready to actually use them. Yeah. So it's great to know that they're there.
Yeah, lots of things that happen in life that mean that you have to postpone things. Certainly COVID is being one of those things for people right now, and it's being reassured that once you've got things, like once I would say to people, once an embryo's in storage, it's frozen in time. Like, you know.
Yeah, so if you create embryos...
You've almost bought a little bit of time with that.
So if you create embryos when you're 32 with 32-year-old eggs, and then you don't use them till you're 35, 36, 37, they're still 32-year-old embryos.
Yes. Yeah.
Which is pretty cool.
So it's just... You know, it's not impacting, it's not, sometimes people ask that, but they worry about the freeze process and how that can impact, and it's certainly not anything to be concerned about. Yeah.
Okay, cool. So then the other kind of main thing that we're doing is egg freezing, which is really exciting.
Yeah. So egg freezing has been around. It's an option for women for as long as I've worked in fertility.
So anyway. Probably would have originally been only or mainly for people going through kind of certain medical treatments. So obviously people would associate it with maybe somebody going to, unfortunately, start treatment for cancer and things like that. But certainly we're seeing changes in that with people freezing eggs to try and preserve fertility. And even so, as I say, in the short time that I've worked in fertility, I'm seeing the difference in that, and the more numbers coming through. And because, as I mentioned, cost being one of the things that we're that little bit cheaper, certainly we're seeing far more women coming in to have that conversation, and much younger women, because I would have been used to meeting people that were probably a little bit older, because they were the people that could financially afford to do it. Sure. What kind of ages of people are you seeing coming in?
We're seeing people coming in their kind of late 20s now, which is
amazing. Yeah,
it is. Now, not everybody's
suitable or needs to or wants to go through,
but they're coming in and having a chat, and it's on their radar. I think I see both sides of it. People that come in and are quite adamant, people that are just a bit unsure, and then when they actually find out what's involved, or like, whoa, that's nuts.
I know, because you probably get people coming in who are like, oh, it sounds like a nice thing to do, and it's a bit trendy, and maybe I'll just do this, put some eggs on ice, and then they realize, oh, I have to take medication, and I have to have a procedure. And
I think you kind of see both. You'll see people that come in and they're really educated on it, and they know what it involves, and then the next person that's just kind of I suppose it's something that they've started to hear little whispers about, and so they want to get more information. Yeah,
it's certainly something that's being talked about a lot more. I think even since, we went into a pandemic, I think people are just kind of talking more. And
yeah, definitely. I saw a big change in after COVID, I think a lot of people thought that it would impact on people being able to afford coming through for treatment and things because people lost jobs or things like that. But it had the opposite effect. It completely changed people's perspectives. I were meeting people that had said, we were due to get married, we'd postpone it, and now actually our priorities have changed, and this is what
that's
we're going to
exactly
focus
what
on.
It is. Its priorities have changed. So even if, financial situations are, slightly different, people are choosing where to spend their money now, I think. Yeah.
And the thing was that people weren't going places, so they had saved money. So that was it. Certainly
no holidays, so let's have a baby. Or freeze eggs,
So that certainly, but the biggest thing, like you say, the change in priorities, I think.
Yeah.
But with the egg freezing, and even, things like where different companies are sometimes offering it as well, that's became more of a talking point, I think. Yeah. I think sometimes negatively, which I don't know that it should be. I think that it's anything that encourages people to be more informed is a good thing.
Yeah, I've been talking to a few people about egg freezing in the last few days, and the way I kind of see it is like, if you know that you may at some point in your life need a blood transfusion and no one else is going to be able to give you some blood, surely you would go and store some of your own that could be potentially used. Probably won't be. And it's kind of like the same with eggs. The majority of people who freeze eggs don't actually ever need to use them. Yeah. But it's just a little bit of peace of mind. Hopefully you'll get pregnant easily, but you may not.
Yeah. And I think we used to talk about egg freezing being like an insurance policy.
It's not. It's really not, because there's no guarantee, even if you needed them, that any of those eggs would result in a pregnancy.
Yeah, but we kind of say it's better than doing nothing.
Yeah.
And I think if it just makes you feel a little bit more comfortable, being a little bit more informed, then
I think it even makes people, as you say, kind of just be that bit more aware and have it in the back of their mind that even if someone has frozen eggs, they probably will kind of plan things out a little bit more and kind of just be more aware and make sure to kind of get regular kind of health checks and that sort of thing, just because it's just kind of taken away there,
And sometimes when people come in for a consult for maybe egg freezing is what they say, but actually it's just they want a little bit of reassurance, fertility testing, and then you can say, look, if you're in the same situation in a year or 2 years, then just this is something maybe you just will be booking in for, that you'll check your AMH a bit more regular, and it's just something that's on your radar. And far better to be proactive like that than to be, because I meet people all the time who are saying, I'm like, I wish I knew. And I wish that I had done something about this sooner. And
Okay, so testing. Let's talk about testing, because a lot of people do come in for testing and then don't go on to do any treatment. So what are like the kind of the main tests for men and women?
So I suppose there's a baseline investigations that we would do for somebody that was coming through for treatment, but there's some even a bit more stripped back for somebody that's just coming in for initial investigation with a bit of a query for fertility.
And is there like a kind of package they can do?
So if somebody was coming through, so we talk about a female fertility profile, and that's for somebody that essentially is kind of thinking about going ahead with a treatment plan. We're looking at doing some baseline investigations, so checking like a full blood count, check they're not anemic, things like that, checking their rubella status, that they're immune, checking their thyroid, because we know that can impact a lot in fertility and implantation. Checking a chlamydia and gonorrhea test to make sure that that's clear, and then the most important one in that, the AMH. So the AMH, or anti-Müllerian hormone, is the most associated test for female fertility. It's an assessment of ovarian reserve or egg reserve. I always explain to people it's a measurement of a hormone. It's not, sometimes people will get a result and they're like, does that mean I've got 10 eggs left?
Yeah.
No. it's an assessment of that, as I say, ovarian reserve. I always say to people, there's limitations to the test. When we do it, I don't know what a person's egg reserve was like 2 years ago, and I don't know what it's going to be like in 2 years' time. It's looking at the here and now, and it doesn't give us anything. It doesn't tell us anything about egg quality. There isn't really any testing that we can
except if you try to do IVF, that's kind of a test.
But I can't assess that on somebody before treatment. But AMH is how we then interpret that as a fertility clinic. Is firstly, it helps us guide someone to how potentially proactive they'd need to be with proceeding with an intervention of treatment potentially. We use it if somebody's going ahead with treatment to guide their medication doses. And it can also just help us guide that person to what we think are sort of realistic egg numbers that they might collect. And
expectations, kind of like
absolutely.
Managing that. And then what are the other investigations? There would be scans.
So that's a really good thing to bring up. The scan is an important part of that as well. So when we're looking at egg reserve, the AMH is part of that, but there's a second test that we would always do sort of hand in hand with that, is something called the Antra follicle count, and that's essentially me looking at the ovary and counting the little potential follicles that are there. And we'd hope that the AMH and the Antra follicle
would kind of match up.
They should marry up.
What would happen if they were like wildly different? Would you kind of repeat?
So sometimes sometimes we don't repeat it. But it just changes maybe again. So I said sometimes it guides us with the medication doses that we give. So if we just went off of an AMH and that was maybe a higher number than we'd seen on the follicle count, then so if we look at both, then it can help us amend the doses.
Because you don't obviously want to be giving someone too much and overstimulating, and then you don't want to be giving them too little, and then you're not getting the results that you're expecting.
So all of the scanning, or sort of, I would say 99.9% of the scanning that we do in fertility is vaginal scanning. Okay. People's faces is sometimes harder when you say that. And back to my, as I always say, better ways to spend your time, but it's not, totally, you can. I've
had millions of them, and your first one, it's kind of like, oh, okay, but
I've had a few, and I think
it is what it is, and it's fine. It's nowhere near as uncomfortable as like a smear test at all,
and that's what I'd sort of say to people. So we're not passing a speculum or anything like that. So the main thing to kind of, I would say to people is, firstly, it's something that is for us, we're doing all the time. Okay, understand that's completely different for the poor person that's coming in to have that, but that we're nothing that question or your anxiety is not going to be anything that somebody else hasn't asked us. People will be like, oh my god, I haven't shaved my legs, or I'd never notice.
Or even like if you have your period, you can still do the scan. I'm sure people would be very like, oh my god, you can't do it, but no, you can. You
can. It doesn't make a difference. So there are some scans that need to be done at certain times of the cycle, but most of them we can do regardless if somebody's got their period. So what we do is you would be brought through into the scan room. We have a chaperoning policy there, so
does that mean if someone wants someone to be there as well as the person who's doing the scan?
Actually, so you can have somebody with you, or if it was a chaperone, that would usually be provided by the clinic. So I would have maybe a second nurse with me. So regardless if it was me that was doing it or if it was Dr. Kennedy that was doing it, you can ask for another person to be in that room with you, and that's really important to make people feel that they're, I suppose, as relaxed as they can be, or safe in that environment. So when somebody's having a vaginal scan, we're going to ask them to take off all of their bottom half. They've got a little sort of paper to cover over with. We do have stirrups on the bed that you have to pop your legs into. And then the procedures that we have a scan probe that there's a little sterile.
It's lovingly referred to as Wanda.
Wanda, yeah.
By anyone who's gone through this.
We were joking that I could get you to just come and help with a few scans for Ranae, because I think any patient that's going through treatment feel like
they'd be able to do. I'm sure I'd be able to do a scan.
Yeah, and do you know what that's like? If somebody was particularly anxious, you can pass the probe yourself. Absolutely.
Oh, I didn't even know that.
Yeah, if I had somebody that's
amazing,
particularly anxious and things, sometimes, and that might be I'll stand behind the curtain and they'll pass it and tell me to come in, or I'll hand it to them and I'm there and they can just pass it themselves.
That's amazing. I didn't know that. I don't think I would want to do that, but some people might, and it's just nice to have those options to make you comfortable.
Why people find these kind of things harder than others, and for some people that little bit of control just helps them. And that's, I should say, like, if you're having a scan done by somebody, you know, and I'll always say that if at any point you're this uncomfortable, you want me to stop, don't need to be polite, just shout at me, tell me to stop. Like a scan, be 5 minutes, could be 10 minutes. It just depends on what type of scan we're doing,
what you're looking at.
Yeah, the sort of initial ones are more like an assessment scan, and they take a little bit longer because we're looking at a few more things. So we have a good look at the uterus, we have a look at the ovaries. If I'm doing just a baseline ultrasound scan, I can't look at the tubes on an ultrasound scan, and you can't make diagnosis of things like endometriosis and things like that. Sometimes people think that you'll be able to see that. Sometimes you'll see things on a scan that you know then warrants more investigation, and maybe it's a little red flag. I'm thinking maybe there's something there, but I can't make those kind of diagnoses off scan. So I spoke about the tubes. There's a different type of ultrasound scan that we do to assess the tubes, and that's something called a HyCoSy. So a HyCoSy is essentially a tubal assessment scan. It's a bit like a hybrid of a smear test and a scan, so a little bit more uncomfortable than just a standard scan, because what we do is we pass a speculum, we pass a little catheter through the cervix, and then we inject a solution through that catheter. And what we're doing with that is we're trying to we open up the uterus, and it gives us a better image. So we're looking to see that there isn't anything we don't want to see, so things like polyps or fibroids. And then we inject a second solution, and that's the solution that shows up on ultrasound that we see.
So it kind of lights up.
Yeah. So
I have this image of the HyCoSy as like, you know, this radioactive.
It just shows up as really bright white on the scan, but you can see it kind of going through the tubes then. And that results of a HyCoSy are instant, so we know right away. We're going to talk you through it, but that's how we assess if a tube is open.
Okay.
We actually recommend doing that type of scan for most patients, even people coming through for IVF. And the reason being that, as I mentioned, the assessment of the uterine cavity, because when we're trying to help somebody get pregnant, we're looking at egg, sperm, and then where we're going to put that potential embryo as well. Yeah. Okay.
So these are kind of the female tests.
Yes.
Let's talk about the male tests.
Yeah. So male testing, it's funny when I'm meeting a couple, I always go through and I've got a big long spiel about the female, and then I look to the man and say, it's going to be much shorter and quicker for me to talk to you about this. Yeah. So it's just usually a straightforward semen analysis. So we ask the male partner to come in, they're going to produce a sample, and that's going to go into the lab. And that's so when we talk about basic semen analysis, that's the embryologist looking at the sperm under the microscope there in our lab, looking at the volume of the sperm. They're looking at how it's moving, how it looks, and that's essentially the most in-depth kind of testing that we do for most of the male partners. Sometimes we do a slightly more in-depth semen analysis, something called the DNA fragmentation test. And that is when that sperm sample is sent off to actually look at the DNA makeup of that sperm. We don't recommend it for everybody. There are certain things that when I meet somebody might be little indicators to do that. So things like if a person was on certain medications, so things like blood pressure tablets, things like if a person was a particularly heavy smoker, we ask about their occupation as well, because sometimes if people have got jobs where they're maybe exposed to chemicals and things like that, they are things.
Yep.
Also just if there's like a history of recurrent miscarriage,
Yep.
or sometimes a period of time that a couple have been trying to get pregnant without any.
So just kind
pregnancy.
of unexplained.
Yeah. As I say, all of these things are really individual. Sometimes for the male partner, we might need to do additional testing, so hormone testing or genetic testing, but that's usually something that comes as a result of the semen analysis. So if there was anything that came out of that, it may indicate that we need to do additional testing.
Yeah. Okay. So that, as you say, it's like big long list for the female testing, and then there we go. But that's essentially what you need.
It is, yeah. And the poor men are sometimes sitting there feeling bad about that when you're sitting, but I'm like, that's essentially all that we need to do for them.
Okay, so let's circle back and talk about the cost, because we haven't mentioned any prices yet. So how much is IVF?
So when you're looking at an IVF, it is $3,995. Okay.
And what does that include?
Okay, so an IVF cycle, so it includes everything that you would expect to include in that. So that would be the treatment plan, the monitoring, the issuing of prescriptions, the monitoring scans, the egg collection and sedation is all included in that. We've also included in that the blastocyst culture and embryoscope.
And those are two things that sometimes are billed as add-ons.
Yes. Yeah.
So why is that included in the package? What's the logic behind that?
Yeah, so IVF in its infancy, we didn't do things like blastocyst culture or growing embryos onto day 5, but as what we did improved in the labs and things, and we started to do that, when we started to culture embryos onto day 5, because it was something new and we were keeping embryos for longer, I suppose essentially there was a charge for that. So that historic charge just sort of stayed there. And so for other more established clinics, it becomes harder to, I suppose, take it away. Yeah.
So like people would have the culture to day 3 included, but if you want to culture to day 5 or 6, it's going to be a charge. Yeah.
But as us coming in as a brand new clinic with a really efficient lab, we know that actually it doesn't cost us anything more to do that. So we're not going to be adding a cost onto a patient.
And also that it's more effective.
Absolutely. Yeah. It's, that's what we want
the standard.
to do. Yeah.
And what about the embryoscope?
Yes, the embryoscope, it's the same kind of story. It was embryoscope is actually something that I saw coming in when I started in fertility.
It's very cool, isn't it?
Yeah. So embryoscope essentially is a type of incubator. It's what we call closed incubation with time-lapse imaging. So it means that we put embryos in and we don't need to disturb them. So when we don't have that time-lapse imaging, what they would have had to do before would they have to
take them out and disturb them,
put them under a microscope, look at them, and they had very tight windows of time that they could do that in. And obviously when you're taking them out, you're exposing them to the environment in the lab and things like that. So in the embryoscope, you don't need to disturb them. You can control that environment very closely, and it means that you've got this continuous monitoring. So if you took an embryo out at one stage to look at it, and it maybe looks like exactly how you expect it to be, but maybe it did something weird and wonderful to get to that stage, which you wouldn't know about
if you didn't have the time lapse.
Yeah, when you've got the time lapse, you can say, actually, this
and
embryo,
then you might choose not to use that one.
So
and
you
use
would
a
say,
different one.
so actually, but this other one here has done everything that we expected it to. So, and that grades it a little bit higher than the other one.
Okay, so that's included.
Yes.
And then the actual freezing of embryos?
Yeah, freezing. So the freezing process is also included in that. So once you have anything in storage, so egg, sperm, embryos, there is a storage fee of €18 per month for that.
And that's different to other clinics where you'd normally pay yearly?
An annual storage fee, or sometimes like a 3-year period, something like that.
That's a bit annoying to pay for 3 years if you might use them in 3 months.
And that's how I'd explain it to people. Say the reason that we're doing this monthly is that firstly it's a smaller manageable cost, so you don't have to suddenly find a big chunk of money when you've just paid for an IVF cycle, but also if you have an embryo in storage and you use it, like say within a few months period, you've not paid for an annual fee.
Yeah. Okay. So what is not included in the cycle? Because sometimes people kind of get confused about the testing, and is testing part of treatment?
Yeah. So there's a couple of things that's not included in a cycle. Firstly, the medications.
And that goes for any clinic. Because sometimes people are like, why are you not including the medication? But no clinic includes medication.
No. But we are very lucky in Ireland that fertility medications are covered on the drugs payment scheme. So I think it's €114 that a person pays for that. And all of the medications that we're going to prescribe for a cycle will be covered on that.
So you'll pay it once in a cycle.
And when you pay the drugs payment scheme, it's not like you don't have to pay to sign up to that or anything. You just pay the month that you need the medications. And the important thing, I know 114 is still a chunk of money.
Well, it's a hell of a lot different than what the alternative would be, because they're expensive medications.
Run into thousands of euro. Like I've seen people paying nearly the cost of an IVF again for their medications. So we're really lucky in that respect. So that's not included. That you pay that to your chosen pharmacy.
So you'd be given your prescription by the clinic, and then you'd go to your pharmacy and do that.
Absolutely. Testing, as you said, isn't included. So any of the baseline investigations that I have already spoken about that we recommend, they're not included.
And what is the kind of price range to give people an idea?
So I feel that we're really competitive with that as well, Ranae. So we're talking at the we have a female fertility profile. So all of that testing I mentioned, the AMH, the rubella, the thyroid, chlamydia, gonorrhea, full blood count, €200. Okay.
Very good.
Then we do the scan. If somebody needs a scan, it's €100. If we're doing a high COSI, it's €300. A semen analysis is €100. And then we're also looking at the DNA fragmentation test, which is $300, but you don't have to have, if you're having a DNA fragmentation, you don't pay for a semen analysis as well. That would be carried out as part of that test.
Okay. And another thing I think that's important to note here is that if you've had any of this testing done previously, a lot of the time we can accept the
transferable
results.
The only thing really is that I want the results to be within a year.
Because and also, like, obviously you just want people to have the best shot at a successful cycle or whatever they're looking at doing.
Absolutely.
And to have the most accurate picture of someone's fertility health is what's going to help you to do that.
And so I would always say that people, like, sometimes they'll come in with some of the testing done, and that's great. It's transferable. And likewise, if you have testing done with us, they're your results.
You can go somewhere else and use them. Yeah, absolutely. So then let's just talk about the initial kind of consultation, because before someone decides to go ahead with treatment, they're going to come in obviously for an initial consultation with one of the nurses, and that's totally free, which is amazing.
Free of charge,
because that just allows people to come in, have a look, meet everyone, and just kind of get a feel for the place, for the people, and have a chat about what they'd like to do with no obligation, which is really nice.
So I think that's fantastic. I love that we're doing that, and I think you and me have spoken about this before, that I think patients like seeing a nurse first, because I think making that first step to come into a fertility clinic in the first place is difficult.
Daunting,
and then they come in, they kind of have that. So our process is that you'd come in, you'd have that consultation with the nurse. I'd recommend the kind of testing that I want you to have done. You'd have that testing, and then you'd come back and you'd meet Dr. Kennedy or one of our consultants,
who would interpret those results and talk about kind of next steps. So, and what the charge for the doctor consultation is?
So €100 to meet with
again, which is, I think, a bargain.
Certainly is. I mean, it's not much more than you're paying to see a GP, and certainly cheaper than I've paid to see consultants previously. But it just means as well, I think you've been in already, so a little bit of that anxiety is maybe just gone,
and there's kind of a full picture of what you want to do. You have your testing done, you've had the initial kind of all of those details taken and those conversations, so that by the time you get to a consultant, they also have a very you're getting you're really making the most of your time. You're not starting from scratch.
And when when the nurses meet the patients, we're very much giving them an idea. We're giving them a lot of information before, and then we're sending them off as well with some information. We're giving them the consents as well, so that they're getting a chance to look at those. And I always say to people, have a look at that, because if you've got any questions, and I'm saying, write those down before, so when you come back, you know that you're going to see him and you can ask those questions. Because I think a lot of the time people would come in, they see a consultant first, and then afterwards
they're like, oh, I wish I'd asked that.
Yeah. And I know from previous experiences, people go in and see a consultant, and then you're nearly repeating the consultation with them again on the phone, or so I think our experiences, we're seeing that this is working a little bit better for patients.
I won't go through all the other kind of costing options, but they are, they're on our
website.
They're on our website, and it's very competitive and very much more accessible. And I think also to mention that we do have our payment plan, which is different again, which is an amazing option to be able to offer to people, that if they apply for finance and they choose to go with the financing option, they can start their treatment immediately. And that's a good thing. Sometimes people think that they would have to
pay that off before,
but
no, it's just an option to help you out there. As well, you might have some of the money saved already.
So you might only want to finance part of it.
It's just there as it's another option, and it's something
that's what it's all about, isn't it? It's giving people options, giving people ownership over what they want to do with their fertility. Okay. I'm going to finish up now by asking you some frequently asked questions, because there are some things that kind of come up time and time again. One of these is, how many visits, let's just take a standard IVF cycle, how many visits to the clinic is someone going to need to make? Say we have someone coming from Cork or Galway and they're making that trip. How many times will they actually physically need to come to the clinic? And can any of that be done virtually?
So I would say once you're actually in a treatment cycle, you're looking on average 3 to 4 appointments. Fortunately, those appointments can't be virtual because they're the actual scans and egg collection procedure, and also the embryo transfer as well. So with the scanning, they're usually happening alternate days, and it's a sort of 15-minute appointment. You're in, you're out.
And they're early in the morning usually.
So our scan lists do run early. And the reason that they happen early is because sometimes when a patient comes in for a scan, we might need to do a blood test as well. And we need those results back the same day. So we need to get that bloods taken and sent out to the lab early. So most people are able to sort of pop in for their scan and then go to work as well after. Obviously it's different if you are traveling quite a distance, but we give people plenty of warning about when they'd be expected to come in. We kind of tell them provisional dates for the first 2 scans at least, and when we think egg collection would fall. So you're looking at, as I would say to people, 2 to 3 scans, then an egg collection procedure, and then about a week later then your embryo transfer, hopefully.
Perfect. And if someone is, say someone is based close to the clinic, they're not having to travel too far, are people going to have to be taking time off work? Are there any days that they have to take off work?
Egg collection, you absolutely need to have the day off work because you're being sedated. So I don't think anybody's going to welcome you in an office doing, I don't know what you might be doing then after that. It'd be an interesting day at work. But no, you're not going to want to do it anyway. So you need that day off. And I always tell people, take the next day off as well. Some people will say you could go back, but I always say, well, sedation, it's a 24-hour thing. So you need to think about if your sedation is at 12 o'clock in the day, you shouldn't be driving for sort of 24 hours. And just,
just remind yourself.
You've asked your body to do a lot. And I think
it's just nice to have a bit of time to chill.
Absolutely, on the sofa.
Especially if you're planning on then having a fresh embryo transfer, as some people may be doing. Kind of just to gear up for that. Because if you're having an egg collection and then you're having a fresh embryo transfer, that potentially could be 5 days later. Okay, next question. A lot of people want to know about the actual medications, like the injections. Are they painful and do they make you crazy? Two different questions.
Do you know what? I think people worry about that so much. And what I would say to people is that they worry more about it than what it actually turns out to be. Are the injections painful? So, like, back to my kind of tagline, I think I should have it tattooed that, better ways to spend your time. I think nobody wants to do them. They're manageable. I think the longer that you're on them, you probably get a little bit more sensitive and things, but, it's a short time frame that you're on them.
And they're teeny tiny needles, like they're really small.
They're what we call, we call it subcutaneous, which essentially means it's just going into the kind of fatty tissue or the skin.
Yes, so it's not going like deep into the...
Yeah. And just the thing is, we've got little demonstration videos on our portal for patients.
Made by a wonderful instructor.
When my partner saw him, he was like, "Did you not have a script?" He wasn't very impressed. I think he thought it'd be more professional. I was like,
they're lovely. I've heard lots of people saying that they're very helpful, and you can they're on your portal and you can just...
Yeah, and you can pause them and, do a little bit at a time. And then, when people come in for a scan, they're like, "Oh,
you're the one on the video."
Yeah. So, but that's, at least you've got that. And I think that's far better than coming in and having an injection demo,
and then you're not going to remember it. Yeah.
So they're there on your portal. They're there for all the time. As I said, you're kind of taking these. We prescribe enough for 14 days, so you've taken them for that, and then you've got a wee break between egg collection, and then you start back onto another injection that you'd be taking hopefully up until an early pregnancy scan. Then.
Okay, and do they make you a bit
so
hormonal?
What I kind of say to people is it's so personal to every person.
Yeah, it's very different. Like some people find them really like you really don't feel like yourself, and then some people are like, oh well.
Yeah, and cycle to cycle can change. Sure. You might meet people that have done a few and they've been fine on them for the first 3 cycles, and then they've got one that's just a rogue cycle there for them. But headaches, certainly people, if you're a wee bit prone to that, kind of premenstrual and things like that, you're probably going to get that. Yeah. Safe to take paracetamol. Drink lots of fluids when you're on these medications. People sometimes ask about alcohol and things when you're on it. I'm never, really, you should be looking to cut back on what you're doing, but there's no contraindication as such. But I would kind of say to people, it's probably more the case that if you have a glass, you're going to feel a bit more like you've had a bottle. So it's probably not a good idea when you're actually on the medications. Yeah. And then mood wise, again, some people find them a little bit more taxing than others, but most people are fine. I think you're kind of concentrating so much on everything that you're doing that you probably, don't think that it's that
eye
bad.
On the prize.
Eye on
the prize,
and that's it. It's certainly, if it's something, we just encourage people to talk to us about it anyway.
Absolutely. Okay. What is the main form of communication between nurses and patients, or doctors and patients? And that's something that we get asked a lot.
So in therapy, we have a patient portal, and that is our primary means of communication. That's how you're going to get in touch with us. It's how we're going to get in touch with you. The majority of all of our communication will be through the portal. Obviously, there's times that people might need a phone call. And that's up, and sometimes people will request to even, sometimes you're back and forth in the portal, and you might just, and
they're like, hey, I just want to chat to you.
Yeah. And that's fine. And that's what we're doing. But I have to say, my experience of working elsewhere with when we're doing phone things and that, you're constantly playing phone
leaving
tag,
voicemails, getting missed calls,
and it means that you've got your instructions once we send them there,
and you can look back on them. You don't remember what you said in a phone call.
Yeah. So that's what we're using, and I think we're getting really good feedback from patients.
Working really well.
Yeah.
Okay. Another thing people are asking is, can you do things like egg donation, PGAT, testing that are not advertised?
Yeah. So those things are not advertised on our website because we don't do them. I mentioned at the start that, we've all sort of came from clinics where we did offer these, and there's absolutely a place for those kind of add-ons, but they're not things that we're offering at therapy. And I have had some patients who came in and with the intention of wanting that, and just didn't realise that we didn't offer it.
And I think one of the reasons, I know from talking to Dr. Kennedy at least, is it's kind of like we're a brand new clinic. We want to be really, really good at doing the things we do. And that's one of the reasons for it. It's not to say that it's not needed, it's not valid.
Absolutely. And I know that certainly, egg donation it's really difficult for patients, especially, and COVID really impacted in that for patients. But it's just not a service that we're in a position to offer at the moment. But we certainly will give people as much guidance as we can and send them in the direction of clinics that we know can help.
It's not just going to be, no, we don't do this, goodbye.
Do this instead. Or we are going to help
direct
patients.
Them to where we think would be best. Yeah,
absolutely.
Okay, last question. And it's something that's very hard to answer. It's how long is a piece of string? But what is the chance of someone having success with a cycle of fertility treatment, and what would you say to anyone who's maybe thinking about taking those first steps?
So it's exactly what you say, and that's what I say to people. That's a how long's a piece of string question. When it comes to success and statistics, it's so personalized to a patient or a couple, because that person's baseline is going to impact on what that outcome could be. So when people come into us, you've already made the first great step. You're being proactive, you're coming in, we're going to do the test. And what I'd say to them is, so when you come in to meet me for a nurse consult, we're going to get that test in, and you're going to go in and meet with Dr. Kennedy or one of our other consultants, and they're going to go through that, and they're going to interpret those results, and they're going to be able to give you a bit better of a guide on
so
what
they won't
success
they won't be able to tell you exactly, like you have a 50% chance, but they will be able to kind of give you an idea.
And I suppose I was talking about this about not wanting to be a big black cloud, but I'm always saying to people, nothing that we do is a guarantee. And sometimes I do meet people that's a shock for. And when I do talk about sort of rough statistics, that they're really taken aback by that. But it's just trying to be realistic. And as I say, you're in the right place. Yeah. That's what you're doing. This is the being in a fertility clinic and getting testing and potentially going with the treatment is the right step. And
it's doing improving. Something instead of doing nothing.
Yeah,
so
absolutely.
You have a chance as opposed to no chance.
Yeah.
And, I'm sure you see it varies wildly, that people who have, really, really, good chance at a successful outcome and it doesn't necessarily work. And then you have people who really had a very small chance and it works. And that's the nature of...
It is. And it's the hardest part about it, I think, for patients. And, I know it's not the same, because it's completely different for me to say it's the same for us, but it's difficult for us as the people that are treating you to try and to see that as well. But what we're trying to do is just empower you as much as we can and
just give people a shot.
Yeah, absolutely.
Okay, well, thank you so much. This was lovely, and I think we could have gone on for a few hours, but we'll stop.
Yeah, Renee's like, please stop.
Thank you.